In this video, I am going to show how experts manage a case of posterior capsular rupture. Also, at the end, do not miss why this posterior capsular rupture actually happened. So, this was a routine case. It's a posterior subcapsular cataract. It's not a posterior polar cataract. So, I didn't expect any posterior capsular rupture here. Capsulorhexis is done using the forceps, a good hydrodissection, you can see the wave there, and rotation is achieved, followed by phacoemulsification. Now, because this was a soft grade of cataract, I generally use the trench and divide technique. So, I have done the first trench here, divided into two heminuclei, then each heminucleus is further divided using the trench divide method. All going well there, and I could see no problem. And once the quadrants are there, which are well separated, I am going ahead with the quadrant removal with my usual settings, keeping high flow rate and high vacuum going up to 700. Two pieces done there, and there I kind of sensed that something was wrong, and that's the reason why I just slowed down there, and you can see that there is a sharp margin which I could notice on the posterior capsule, and also I could see some small cortical material which is deeper than the posterior capsule, and this is why I kind of got distracted and caught hold of iris. I emulsified the remaining the epinucleus there, and then I injected OVD because I was suspecting already posterior capsular rupture, but despite injecting the OVD, you could see that happening. And what happened there? So you can see that the posterior capsular rupture margin is already seen there, and there was a circular opening right in the middle, which indicates a ruptured anterior as well. So now the vitreous is now prolapsing into the anterior chamber. So obviously now I have to take care of the vitreous before I proceed. Now I am doing this surgery on topical anesthesia. Now the eye movements are not good while managing the posterior capsular rupture. So I decided to give a posterior subtenon anesthesia using 1 cc of xylocaine. This makes it more comfortable for the patient. Also, patient doesn't exert more pressure. I am going to make the second MVR entry because I have made only one to begin with, and there goes the 23 gauge vitrectomy cutter through the side port, and it goes right through the PC rupture area, and while bevel is downward, I am going to cut it using 5000 cut rate. The flow rate is 30 and the vacuum is a linear fashion from 0 to 500. We can also keep lower vacuum if you are using low cut rate. And bottle height is important. We should not use very high bottle height here. So I have kept the bottle height equivalent to just 30 pressure. Now once the vitreous is cut from behind the posterior capsule, when you go right through the posterior capsule right at the beginning and start cutting, you will find that you generally don't allow the PC rupture to enlarge further. And once you have removed the vitreous, what I have done is now I have shifted to IA cut mode, where the vacuum comes first, and if I press the pedal further, then only cutting comes. Now using the IA cut mode is useful when vitreous is still prolapsing, but otherwise it's better to use the bimanual itself, because bimanual is less risky or less traumatic for the anterior capsulorhexis margin. Now here I am trying to remove the inferior cortex going through the main incision, but we must try to be more careful while doing this because we don't want the anterior chamber to collapse while doing this. You could see that little bit of cortex has dropped down, but I'm not worried about that. And luckily, with the fluid, it just came out. But don't go after these little cortical matters which are falling behind, because you may create undue traction on the vitreous. Now I have shifted or changed my hands, and from other side I am removing the cortex. Again, I am using the vitrectomy cutter itself on IA cut mode. Vacuum is linear from 0 to 500. I have increased the IOP to 40 now because I have already removed the vitreous, and the flow rate is kept low at 10. So I have got better control on the aspiration of the cortex there. This is a step which requires little bit of patience. So once you have a complication like posterior capsular rupture, we must carry out all other steps with most patience and also with mindfulness. Now here what I have done is that I have shifted from the vitrectomy cutter to the cortex aspiration, which is bimanual cortex aspiration. Here I am sure that vitreous is not there, and you will find that using the bimanual eye is less traumatic to the anterior capsular margin, and you are also more confident to take out all the cortex which is remnant. Now in the area of posterior capsular rupture, the you have to be more careful with IA there, because it can pull out some vitreous. So just be careful that you are not pulling on any vitreous strands there. So the margin of this PC tear is the area where you might have to be little bit more careful in order to pull out all the cortex. You can see these margins have already gone past the capsular axis, so it might have reached the equator of the lens as well. Now the question is whether I can place the IOL in the bag, and here it's a toric IOL. So in order to place the IOL in the bag, first I must enlarge the incision because it's a hypertonous eye, and I don't want to push the IOL with the resistance, so that I don't want it to drop into the vitreous cavity. So importantly, I have injected the IOL in the anterior chamber. I didn't try to put it directly into the bag because it might just drop down through the ruptured posterior capsule. Now because it's a toric IOL, I just placed it in the anterior chamber with the same alignment which I want in the bag, and very carefully using Sin's key, I have pushed the haptic into the bag there. Now other method is to use a forceps. So on the other side I am going to use a micro grasper or micro forceps to hold the haptic and then gently nudge it into the bag. So in these cases, avoid the usual dialing method of IOL placement in the bag. So you have to just pull the haptic towards the center and then gently nudge it into the bag. Once this is done, you can see the IOL is well secure in the bag, and fortunately here the posterior capsular rupture was perpendicular to the placement of the IOL. Once this is done, using very low IOP there, you can see I am using 20 IOP. You have to use very low bottle height to aspirate out the remaining of the OVD there and hydrate the incisions properly. If you ever feel that the incisions might have some leak, it's better to suture the incision. And this patient I have given subtenon block, so within half an hour I am going to open the pad and start using the topical antibiotic and steroid drops. So I am not going to suture it here because I feel the wounds are quite tight. The IOL is well placed in the axis where I want, and you can see at the end there. With posterior subtenon block, usually you have good eye movements. Now this is 1 week after the surgery, and you can see that the IOL is well placed in the bag. You can see those toricile markings there. And on the iToric app, this is the iToric Patwardhan app, which shows that IOL is rightly placed on the axis that I want. Now, let's find out why there was a posterior capsular rupture. So this was the moment where you can see that I was trying to take out subincial quadrant, and I was trying to emulsify it then and there itself, and that's why it just punched through the soft quadrant there and punched the posterior capsule. So I feel that we must understand that the safe zone of phacoemulsification is just 2 mm zone around the center and little bit away from the center. So you should avoid the subincial area for doing quadrant removal. It's not really safe, as you can punch through like you have seen here. So we saw how it was managed and also the safe zone for quadrant removal. For more comments, do write and do subscribe to my YouTube channel. Thank you so much.